Sir, am I audible?
Yeah, very clear.
Okay, thank you, sir.
We are live on YouTube. We will start in 1 minute.
Yes, sir.
So are you ready?
Yes, sir.
Okay, fine. We'll start.
So should I share my screen?
No, I'll let you know. I'll let you know.
Okay, sir. Yes, sir.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 16A, which is Hematology Non-Neoplastic Lesions of WBC. We are streaming live from IPGMER, Kolkata. A very interesting basic topic for today's discussion, which is non-neoplastic lesions of WBC session 1, which includes structure and composition of neutrophils, eosinophils, basophils, production, distribution, and fate of neutrophil, eosinophil, and basophils, eosinophil and related disorder, basophil, mast cell and related disorder. To speak on that, we have a very bright, young, vibrant pathologist, Dr. Shristi Butta. She is an MBBS with gold medal, MD Pathology honors. Presently, she's a demonstrator in the famous IPGMER and SSKM Hospital, Kolkata. Her areas of interest are cytopathology, hematopathology, and oncopathology. Before I ask Dr. Shristi to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Shristi, ma'am, please share your screen. Let's start.
Yes, sir. It's an honor and privilege, sir, to be a part of this Pursue series. Thank you so much, sir, for giving me this opportunity. I'll just share my screen. Sir, is my screen visible?
Yeah, please go ahead.
Okay, then. We have our non-neoplastic disorders of the WBC session 1 today. Before I start, I have some disclosures. Contents in this lecture have been taken from relevant hematology textbooks and research work by eminent pathologists and scientists in various fields of medicine and research. This is solely educational and by no means can be used for any other purpose. Now, going back to your basics always strengthens your foundation. So do remember your basics. With this, let's have an overview of the lecture for today. We have neutrophils, structure, development, and functions with a brief overview regarding neutrophil and its associated neoplastic disorders. The next class, however, will be dedicated to neutrophils. Neutrophil extracellular traps will be given a little bit of more emphasis. Eosinophils, basophils, and mast cells with its structure, development, and functions. And basophil activation test will be given a little more emphasis this time. And mast cells and its associated non-neoplastic disorders will also be discussed. So without much ado, let's just start. Now, neutrophils. Neutrophils account for 40 to 70% of the polymorphonuclear leukocytes in the human body. They are the first line of defense in the innate arm of the immune system. They account for phagocytosis, intracellular degradation, and release of granules. They also form what is referred to as the neutrophil extracellular tracts. Yes. Now, the term neutrophil derives from the staining characteristics on hematoxylin and eosin. Neutrophils stain a neutral pink, and that's why the term neutrophil. It has about 2 to 5 lobes. Now, when circulating in the bloodstream and in the inactivated state, neutrophils are spherical. However, once they are activated, they become amoeba-like and develop pseudopods, which hunt for antigens. Neutrophils have a Golgi apparatus, which is comparatively small, mitochondria and ribosomes, which are sparse, and a rough endoplasmic reticulum, which is comparatively absent. Up to 17% of the female neutrophil nuclei have a drumstick-shaped appendage, which is referred to as the inactivated X chromosome or the bar body. Okay, so the figure shown alongside here shows you a bar body. Now, neutrophils have an access to the inflammatory site. They have undergone a phenomenon which is referred to as the margination. Okay, and these leukocytes get redistributed closer to the vessel wall. Now, we're just coming to this picture here. You have the endothelium. Okay, here the endothelium. Okay, this endothelium has the E selectin and the P selectins. So what is the function? The E and the P selectins are molecules which are expressed on the endothelium. Okay, the E and the P selectins. They are responsible for loose adhesion and rolling. The molecule that is correspondingly expressed on the neutrophil surface is the selectin ligand. That selectin ligand is the Cy-Lewis X-modified glycoprotein. This Cy-Lewis X-modified glycoprotein binds to the E and the P selectins expressed on the endothelium. The low affinity integrin receptors on the neutrophil changes into a high affinity integrin. The ligands for the integrins, that is the VCAM1 and the ICAM1, are again expressed on the endothelium. So the loose adhesion is brought about by the E and the P selectins on the endothelium with the selectin ligand, that is the Cy-Lewis, on the neutrophil surface. The tight adhesion, on the other hand, is brought about by the VCAM1 and ICAM1, which are the integrin ligands, and the LFA1, that is the integrin expressed on the surface of the neutrophils. Subsequently, what happens is that there is a diapetesis. The diapetesis, which occurs because of the molecule that is the PCAM1. The PCAM1 is expressed both on the endothelium as well as the neutrophil. Subsequently, there is migration that happens through this extracellular matrix, and that is driven by the chemokines. These chemokines may either be interleukin 8, C5a, leukotriene B4, or H2O2, and kallikrein for that matter. This phenomenon is referred to as chemotaxis. Now, neutrophilia. An absolute neutrophil count defined as the percent of neutrophils in the blood stream and adults ranges from 2,500 to 7,000 neutrophils per microliter. Anything which exceeds 7,700 per microliter, that is, at least 2 standard deviations above the mean, is referred to as neutrophilia. Now, there are various causes of this neutrophilia. One is a factor, the other being free neutrophil. That the laboratory settings. Whereas primary neutrophilia basically happen in marrow disorders. That is, they are basically clonal. On the other hand, secondary neutrophilia is basically reactive and responds to a wide variety of stimuli. Now coming to factitious neutrophilias. Factitious neutrophilia can be seen in the blood samples that are either inadequately anticoagulated with citrate or EDTA-based anticoagulants. That results in what is referred to as the platelet clumping. Okay, and this platelet clumping results in an automated cell counter leading to falsely elevated neutrophil count. A repeat blood sample, however, followed by the examination of the peripheral blood smear, can help resolve this issue. Another possibility is that if you have a precipitated cryoglobins, that is shown here. These cryoglobins that are shown alongside can sometimes be taken by this automated cell counters and can pass through the apertures through which the cell suspensions are drawn, resulting in a spuriously elevated white blood cell or even platelet count. So precipitated cryoglobins in factitious neutrophilia can also result in neutrophilia, Now coming to glucocorticoids and neutrophils. Endogenous glucocorticoids are one of the factors that promote the maturation of neutrophils in the bone marrow, as is very well known to us. Yes, they promote the maturation as well as favor the mobilization of the neutrophils. This is one of the reasons why response to excessive corticosterone release has been observed under stress conditions and leading to neutrophilia. The biologic basis behind it is that there is demarcation be delayed into tissues as well as the release of the immature form of banned forms of neutrophils. So patients with glucocorticoids, even though have neutrophilia, do not have what is referred to as a left shift, generally. Now the cause behind it is the shedding of the L-selectin. The neutrophils express on their surface the L-selectins. Okay, so shedding of this L-selectin results in faster rolling. Rolling, remember the diagram that I was explaining in a bit? Now rolling speeds that favor detachment of the neutrophils from the endothelium into the blood flow. So shedding of the L-selectin leads to faster rolling, and that speeds up the detachment of the neutrophil. If the neutrophils detach from the endothelium, they come into the blood flow. In addition, what happens is that there is prevention of apoptosis of these neutrophils. Prevention of apoptosis of the neutrophils basically arises due to glucocorticoid-mediated induction of the anti-apoptotic BCL2 family protein MCL1. So prevention of apoptosis in addition to shedding of the L-selectin leads to faster rolling, and that subsequently results in neutrophilia. Other causes like primary neutrophilia, which arises from myeloproliferative neoplasms, which is not the topic of discussion for today though, genetic and inherited neutrophilias, and chronic idiopathic neutrophilias. Other causes include congenital anomalies, transient myeloproliferative disorders, familial cold urticarias, and hereditary chronic neutrophilias. There are some secondary causes as well, like bacterial infections. Infections and inflammations, as we all know, result in toxic granules and Dole bodies on peripheral smear. In addition, it must be noted that even though in viral infections there may or may not be a high neutrophil count, but when the neutrophil count is high, it is often associated with atypical lymphocytes as well. Now, coming to the non-hematological neoplasms like solid tumor malignancies, which can also result in a paraneoplastic leukemoid reaction. In addition, medications like all-trans-retinoic acid, GCSF, GM-CSF can all cause an increase in the neutrophil count via direct stimulation of the bone marrow myelopoiesis. Glucocorticoids, as I've already discussed, cause an increase in the neutrophil count by shedding of the L-selectin and by prevention of the apoptotic pathway. Now coming to neutropenia. The common toxicity criteria established by the US National Cancer Institute grades neutropenia as grade 0, grade 1, grade 2, grade 3, and grade 4. However, the term neutropenia applies only when the ANC, that is the absolute neutrophil count, is less than 1500 per microliter. That is anything which is grade 2 and greater. Grade 0 being more than or equal to 2000, grade 1 1500 to 2000, grade 2 1000 to 1500, grade 3 more than 500 but less than 1000, and grade 4, that is severe neutropenia, is less than 500 neutrophils per microliter. Now there are several causes of neutropenia, one of which is the accelerated removal of neutrophils. The accelerated removal of neutrophils from the circulation when exceeds its production results in neutropenia. That typically occurs in infections and inflammation. In drug-induced causes, we have anti-cancer drugs like phenothiazine, thiouracils, chloramphenicol, phenylburazone, etc., which all result in an idiosyncratic depression of the bone marrow function and intramedullary destruction of the granulocytes. Immunological mechanisms are also responsible for this neutropenia. Neoplasms can also result in an overgrowth of the neoplastic cells and result in neutropenia. Idiopathic neutropenias can occur due to autoimmune reactions. We also have Felty's syndrome, where there is an intrasplenic destruction of the neutrophils. Now, what is febrile neutropenia? Neutropenic fever is defined as a single oral body temperature that is greater than or equal to 101 degree Fahrenheit, okay, or a temperature that is greater than or equal to 100.4 degree Fahrenheit for at least an hour, with an absolute neutrophil count which is less than 1500 per microliter. Infections like dengue hemorrhagic fever, Epstein-Barr virus, hepatitis B virus, HIV may be implicated. Bacterias, fungi, protozoans, and rickettsial fevers may also be implicated in a febrile neutropenia. Anything with a count that is less than 500 neutrophils per microliter is referred to as a severe febrile neutropenia. Now let's just move on to what is this inflammation. Okay. Now the basic component resulting in fever is interleukin 1 beta. Okay. So what is this interleukin 1 beta and where does it come from? The inflammasome is a protein complex that recognizes products of dead cells and some microbes and induces the secretion of biologically active interleukin 1. We have three important components. We have NLRP3, adapter protein, and caspase inactive. This caspase inactive changes into caspase active. This active caspase produces interleukin 1 beta, which results in a fever and acute inflammation. This happens only when bacterial products, crystals, potassium efflux, and reactive oxygen species can activate this inflammasome. Now coming to the neutrophil functions, right? Now neutrophils are produced at a rate of around 10 to the power 11 cells per day. Under homeostatic conditions, neutrophils enter the circulation, migrate to tissues where they complete their function and finally are eliminated by macrophages, all in the lapse of a single day. There are three basic functions of neutrophils, right? One is phagocytosis, as we all know. There is degranulation, very well known to us, and there's something new which is referred to as the release of nuclear material in the form of neutrophil extracellular traps. Now coming to phagocytosis. Okay. Now, as we all know, we have opsonins that coat the bacteria or the parasite, which can be engulfed blocked by this neutrophil, the antibodies like IgG or IgA, complement system proteins like C3p, C4p or IC3p, and surfactant mannose binding lectins, which all initiate the formation of C3p, can act as opsonins. Once opsonized, they are phagocytosed and subsequently undergo the H2O2 MPO Halide system type of bactericidal action that happens in the neutrophils. Okay, so this MPO halide system is typically very important. It happens when the O2 in the presence of an oxidase changes into O2 minus. That in the presence of superoxide dismutase changes into H2O2, and that in the presence of MPO or myeloperoxidase changes into HOCl. So this HOCl is very important. Okay, this HOCl or the halide system typically is efficient enough to cause a bactericidal action. But besides this, there is another function of neutrophils, which is netosis. We'll just be coming to that in a bit. Now, neutrophils have several granules: primary, secondary, and tertiary. Regarding the primary granules, which are produced in the myelocyte and promyelocyte stages, the azurophilic or primary granules contain myeloperoxidases, bactericidal or permeability increasing proteins, defensins, serine proteases, neutrophil elastase, and cathepsin G. The secondary or specific granules, which are produced in the myelocyte and metamyelocyte stages, typically have granules like alkaline phosphatase, lysozyme, NADPH oxidase, collagenases, lactoferrins, and histaminases. Tertiary granules, which are present in the band cell stage, have granule-like proteins with cathepsin, gelatinase, and collagenases. Now, what is the function of these molecules that are present within the granules? Okay, they typically are involved in what is referred to as the netosis. In 2004, we had Brinkman and his colleagues who described a striking observation that activation of neutrophils causes the release of web-like structures. Okay, these web-like structures of DNA and histones that were released were referred to as the neutrophil extracellular traps. Okay, and that resulted in a breakthrough. The reason behind it was the fact that it not only influenced inflammation but also thrombosis, cancer, and autoimmunity. Neutrophil extracellular traps comprise a web of fibers composed of chromatin and serine proteases, including the MMP9. So what is the function of this MMP? We'll be just going in a bit. Yeah. Now, coming to matrix metalloproteinases. Matrix metalloproteinases constitute a large family of zinc and calcium-dependent endopeptidases implicated in tissue remodeling and chronic inflammation. MMPs are produced by many cell types, including lymphocytes and neutrophils, but in particular by activated macrophages. MMPs are secreted as proenzymes, which are activated by the proteolytic cleavage and regulated by a family of inhibitors, which are referred to as the tissue inhibitor of matrix metalloproteinases. These groups can either be collagenases, gelatinases, stromylysins, or membrane type of MMPs. Okay, just have a look at the chart which is coming up next. We have class 1 MMP, which includes the interstitial collagenases, neutrophil collagenases, collagenase 3. Okay, and the preferred substrates are given alongside. We have the fibrillar collagens, type 1, type 2, and type 3. Class 2, which includes the gelatinases. The preferred subtypes are collagen 4, 5, and gelatin. Class 3, which includes the strolysin 1 and 2. And the non-classified type or the membrane type of MMPs usually target the progelatinase type A. The function of it will be just shown in a few slides later. Okay. We have neutrophil physiology coming up next. We have this neutrophil arising from the hematopoietic stem cell. This hematopoietic stem cell changes into the multipotent progenitor cell. This multipotent progenitor cell then transforms into a lymphoid-primed multipotent progenitors, which subsequently differentiates to produce the granulocyte monocyte progenitors. And then we all know the stages: myeloblast, promyelocyte, myelocyte, metamyelocyte, band forms, and neutrophils. But how does this neutrophil exit the bone marrow? Yeah, that's interesting. Let's see. For a neutrophil to exit the bone marrow, the integrin alpha 4 beta 1, that is the VLA4, and the CXCR4 are downregulated. Note that they are downregulated, while the CXCR2 and the toll-like receptor 4, that is TLR4, are upregulated. The bone marrow stromal cells express vascular cell adhesion molecule 1, that is the VCAM1, which is a ligand for VLA4. Okay, so it's a bit confusing, right? So let me just explain. You have the bone marrow stromal cells, okay, which is producing VLA4 ligand. Okay, so the ligand for VLA4 is being expressed by the bone marrow stromal cells as well as osteoblasts. Okay, and the chemokine stromal derived factor 1, or the SDF1, which is a ligand for CXCR4, is also being expressed by the bone marrow stromal cells. Okay, why are they being expressed? Because they help in the retention of the progenitors in the bone marrow. Otherwise, all the progenitors will appear in the peripheral blood. It is only when they are downregulated that they tend to appear in the peripheral blood. So, we have osteoblasts and bone marrow stromal cells producing CXCL12, which keeps the CXCR4 expressing neutrophils in the bone marrow. I hope I've made myself clear. It's osteoblasts and bone marrow stromal cells producing CXCL12, which keeps the CXCR4 expressing neutrophils and progenitors in the bone marrow. GCSF induces neutrophil exit by interfering with this CXCR4 and CXCL12 interaction. Outside the bone marrow, the neutrophil production is regulated by a cytokine network, that is interleukin 17. It is produced by T helper 17. Okay, that produces interleukin 17, and that allows for new production. Because osteoblasts and other bone marrow stromal cells produce VCAM1, a ligand for VLA4, and CXCL12, which is a ligand for CXCR4. That keeps the CXCR4 expressing neutrophil precursors in the bone marrow. Because they are retained by the bone marrow, the progenitors do not appear in the peripheral blood. GCSF induces neutrophil exit from the bone marrow by downregulating the integrin VLA4 and the CXCR4. Outside the bone marrow, the interleukin 17 is responsible for neutrophil production. Now, the classical view of neutrophils. Neutrophils were considered to be a homogeneous population. But however, the recent view of neutrophils suggests that neutrophils have a phenotypic heterogeneity and functional versatility, which places neutrophils as important modulators both for inflammation and immune responses. Neutrophil heterogeneity. Neutrophils are transcriptionally active cells with the potential to change the expression of several membrane molecules and to produce cytokines. In the absence of any inflammatory signals, they usually die by apoptosis within 8 to 12 hours. However, in cases of infection and inflammation, the period of their lifespan extends up to 1 to 2 days. Neutrophils change their phenotype over time, and that is referred to as aged neutrophils. Aged neutrophils are smaller, have fewer granules, and a granular multilobular nucleus. Now, neutrophilic heterogeneity. There are several neutrophilic subpopulations, in especially PMN1 produces interleukin 12. So it is PMN1 which produces interleukin 12, right? And we have PMN2, which produces interleukin 10. Right. So what is the difference then? Let's see. We have two pathways, right? We have the interleukin 12 and we also have the interleukin 10. Yeah. Okay. So this interleukin 10 allows for anti-inflammatory effects because it activates the neutrophils according to its alternative pathway. Interleukin 10, alternate pathway. Interleukin 12, it is the classical pathway of macrophages that are activated. So we have two basic pathways of macrophages. One is the interleukin 12 pathway, okay, which results in its inflammation, and we have the interleukin 10 pathway, which results in its anti-inflammatory property. The two pathways are either classical or it is alternate. So you have neutrophils which can activate macrophages both along its classical pathway as well as according to its alternative pathway. Now, inflammatory state induced by obesity. Neutrophils have a role there also. First, the neutrophil release elastase. Okay, this elastase is released by its azurophilic granules. But what is the function of this elastase? This enzyme can destroy the insulin receptor substrate 1. Okay, so elastase typically destroys the insulin receptor substrate 1. That causes insulin resistance and lipogenesis. In addition, during hypercholesterolemia, neutrophils show a primed state characterized by elevated levels of reactive oxygen species, increased release of MPO, and increased expression of CD11B. So what is the implication? The implication is that in hyperglycemia, neutrophils in circulation respond to high levels of glucose by releasing S100 calcium binding protein A8 and A9, which interact with the RAGE, that is the receptor for advanced glycation end product, and induces macrophages and the granulocyte monocyte progenitors in the bone marrow to secrete GCSF. This new released neutrophils produce reactive oxygen species and form nets. So nets are very important. They have been implicated in hyperglycemia and hyperlipidemia. They produce what is referred to as a pro-inflammatory state. Let's move on further. Atherosclerosis. Neutrophils attach themselves to the atherosclerotic plaque primarily through net formation, where cholesterol crystal functions as the danger signal, inducing interleukin 1 beta mediated net release. So if you have an interleukin 1 beta, remember the inflammasome, okay, the inflammasome which resulted in the formation of interleukin 1 beta. So interleukin 1 beta mediated net release from the neutrophils. And what is the function of this net then? This net produces cathepsin G and cathelicidin related antimicrobial peptide or cramp, which can attract more macrophages and monocytes to the plaques. Nets can directly participate in the rupture of the atherosclerotic plaque, which triggers platelet aggregation and fibrin deposition at the site of atherothrombosis. Now coming to acute respiratory distress syndrome and NET. Now this ARDS and COVID-19 SARS-CoV-2 has been like around 2 years we've been just hearing about COVID. So what is the implication of NET in COVID now? In ARDS, NETs are the key elements in immune thrombosis, where they provide a stimulus and a scaffold for thrombus formation, endothelial damage, and organ dysfunction. Elevated circulating markers for NET, remember, elevated circulating markers for NET are prognostic indicators for respiratory support requirement and survival in patients with coronavirus disease. Circulating NET markers of inflammation have correlated well with markers of endothelial and inflammation damage in COVID-19 like IL-6, CRP, and D-dimer. So what are these NET markers? What are these NET markers? Okay, now this is a gray area of interest now for all young scientists. Notably, the assays quantifying the circulating H3 citDNA, okay, that is the nucleosomal citrullinated histone H3. the neutrophil elastases and the cell-free DNA. They are the markers which have been validated in the human plasma and easily accessible for allowing a potential clinical implication. Let's see how. Targeting netosis is therefore very important, as it can open up newer avenues for promising therapeutic strategies in COVID-19. Endogenous deoxyribonucleases dismantles the net and net-driven thrombosis. Removal of this net via recombinant DNase infusion might improve microvascular perfusion in COVID-19 patients. So neutrophil targeted therapy, a paradigm shift, right? Targeting netosis to reduce immunothrombosis in COVID-19 patients. Neutrophils. Now, neutrophils have other types as well, like myeloid-derived suppressor cells. These myeloid-derived suppressor cells are a type of neutrophils. They are the immature precursors of neutrophils, okay, and they are produced in patients with different types of cancer. The myeloid-derived suppressor cells exert an immunosuppressive phenotype that supports the tumor progression. For this reason, they were named as myeloid-derived suppressor cells because of the immunosuppressive phenotype. We also have another type of neutrophil which is called as the low-density neutrophils. The neutrophil is very important because they have the potentiality to express neutrophil-derived matrix metalloproteinase, that is the MMP9. So what is the function of this MMP9? This MMP9 has critical roles in degradation of the extracellular matrix, and it facilitates tumor invasion. Positive contribution of nets on tumor progression and metastasis. So MMP9 plays a critical role in degradation of the extracellular matrix and facilitates tumor invasion. Everything in life goes back to the basics, whether it is COVID-19, atherosclerosis, or for that matter, the low-density neutrophils implicated in tumor progression, metastasis, myeloid-derived suppressors. Everything is just coming down to the basics. Now coming to the next cell, eosinophils. Despite being the second least represented granulocyte, eosinophils are receiving growing interest due to their complex pathophysiological role in the broad range of local and systemic inflammatory disorders as well as cancer and thrombosis. This is thus paving a way to a golden age of eosinophil targeted agents. Along with mast cells and basophils, they also play a critical role in allergy and asthma. These cells are eosinophilic or acid-loving due to their large acidophilic granules. Okay, the eosinophils, everybody knows how they look, right? Okay, now coming to the eosinophil production. Who produces eosinophils? Yes, they are produced by the CD34 pluripotent hematopoietic stem cells, right? But what is the signal responsible for it? We have the T helper 2 cells and the ILC2. Okay, the ILC2 is the type 2 innate lymphoid cell. This type 2 innate lymphoid cell, they are derived from a common lymphoid progenitor and belong to the lymphoid lineage. These cells lack specific B or T cell receptors because of the lack of the recombination activating gene. The ILC2 produces type 2 cytokines like the IL-4, 5, 9 and 13. Okay, 4, 5, 9 and 13, of which 5 is very important. 5 because 5 controls the development of eosinophils in the bone marrow. So that is why it is very important. So T helper 2 and ILC2 cells both express the transcription factor GATA3. Okay. Besides being a very important marker for urothelial carcinomas, let's come back to this. This is GATA3, which is being produced by T helper 2 cells and ILC2 cells. Both express the transcription factor GATA3, which promotes production of T helper 2 cytokines like interleukins, which we've already discussed, like interleukin 4, 5 and 13, of which 4 of 5 is very important because 5 is implicated in the development of eosinophils. Eosinophil development and maturation occurs in the bone marrow over approximately a week under exposure to myeloid precursors 3, GM-CSF, and especially interleukin 5. Chemokines like CCL11, 24, and 26 are typically very important because they eventually promote eosinophil recruitment into the tissues within 8 to 12 hours since their release from the bone marrow. Interleukin 5 is a very key cytokine. Okay, the major sources of interleukin 5 are CD34 progenitor cells. We also have the group 2 innate lymphoid cells, the T helper 2 lymphocytes, invariant natural killer T cells, and mast cells. Interleukin 5 can be released by eosinophils as well in an autocrine or paracrine manner. Now, coming to this picture here, we have interleukin 3, GM-CSF, and interleukin 5. Okay, so they are going to bind to the eosinophil. The common beta chain that is there as the receptor, and there's an alpha chain which changes for all the three. The interleukin 5 is typically very important because it binds to the receptors on the eosinophils and allows for its development. Eosinophil, once it develops within the bone core and matrix for the Charcot-Leyden crystal formation in tissues and fluids. It also has a potential immunoregulatory function towards the T cells. The specific or the crystalloid granules, okay, which contains the major basic protein. We also have the eosinophil-derived neurotoxins, eosinophilic cationic proteins, the eosinophil peroxides, okay, and we also have the lipid bodies containing the leukotrienes and the prostaglandins and thromboxane. The major function of major basic protein is disruption of the lipid layer and increasing membrane permeability. It is also a component of what is referred to as the eosinophil extracellular traps. What are these? We have slides next coming up for that. Okay, we have basophils, neutrophils, and mast cell activation and degranulation, which is again dependent on this major basic protein, which is also neuroprotective and also undergoes epithelial activation and expression of tissue remodeling factors. Increases smooth muscle reactivity, inhibits M2 muscarinic receptors. The matrix contains the eosinophil-derived neurotoxins and eosinophilic cationic proteins with eosinophilic peroxides, okay, which have a role as an RNase. So therefore, they have an antiviral role in single-stranded RNA viruses. They're also cytotoxic. And we also have the arachidonic acid derivatives here, which are implicated in both acute and late hypersensitivity reactions and also have a role in airway remodeling. Now, granule release. How do these granules release from the eosinophils? Now, besides eosinophils, it's the same mechanism that is followed by all other granulocytes, just showing piecemeal degranulation. Now, piecemeal degranulation is characterized by progressive and selective release of these granule content with the help of small vesicles in the absence of any fusion with the granules or plasma membrane. So you have the granules and they are the granules just being released. Okay, so there is no fusion of the granules amongst themselves or with the plasma membrane. When the granule fuses with the plasma membrane and gets released, phenomenon is F2. So, well, exocytosis. What is cytolysis then? There is release of intact granules following rupture of the plasma membrane in cytolysis. Okay, so these are the different types of granule release. Now, coming to the function of eosinophils. Eosinophils, besides having their role in allergy and asthma, also have a role in phagocytosis, cell killing, and antigen presentation. So, how do they kill microorganisms by delivering the major basic protein and the eosinophilic cationing proteins to the intracellular phagolysosomes. Okay. Besides that, eosinophils also are implicated in thrombosis. They have a thrombogenic potential. The reason behind it is the fact that eosinophils express the p-selectin granulocyte ligand 1. Okay. Now, this p-selectin granulocyte ligand 1 on the cell surface of the eosinophils enables the eosinophils for the engagement of the p-selectins to the activated platelets. Okay, so the p-selectins which are expressed on the activated platelets gets engaged with the p-selectin granulocyte ligand 1 on the surface of the eosinophils. Activated platelets culminate in a chronic inflammatory reaction and remodeling, so hence thrombogenic potential can be implicated to eosinophils as well. Now, what are these eosinophil extracellular traps? Are they different from nets? Neutrophil extracellular traps? Yes, they are. The reason behind it is that they are mitochondrial. Okay, unlike the neutrophil extracellular trap, which is composed of nuclear DNA and histones. Eosinophilic extracellular traps have been implicated in atopic dermatitis, eosinophilic esophagitis, asthma, and many more conditions like chronic rhinosinusitis and nasal polyp formation. So they basically are atopy or acne a lot of immunity as generated by production of MMP9. Remember, it breakdown of the extracellular matrix by nets. Now, what is eosinophilia? When an eosinophil count exceeds 450 to 500 cells per microliter, it is referred to as eosinophilia. Anything which is above 1500 cells per microliter is referred to as hypereosinophilia. There are several conditions, one of which is parasitic infection, autoimmunity, collagen vascular diseases, SLE, malignant diseases like eosinophilic leukemia, clonal hypereosinophilias, Hodgkin's disease. We also have a newer thing called as the lymphocytic variant hypereosinophilia. We also have skin conditions, dermatitis, Addison's disease, and other causes of low corticosteroid production, which suppresses eosinophils, reflux esophagitis, eosinophilic esophagitis, and drugs like penicillin. So what is hypereosinophilia? I was already discussed. Eosinophil count above 1500 per microliter is referred to as hypereosinophilia. Hypereosinophilic syndrome, on the other hand, is a condition where there is a sustained elevation of eosinophil count above 1500 per microliter that is associated with evidence of eosinophil-based tissue injury. Okay, so that is the hypereosinophilic syndrome. However, if you have a clinically silent case associated with hypereosinophilia, then that is referred to as hypereosinophilia of undetermined significance. The General Hematology and Hematology Oncology Task Forces for the British Committee for Standards of Hematology, that is BCSH standards, classifies hypereosinophilia into three types. One is the primary or the intrinsic hypereosinophilia, okay, where you have neoplastic eosinophils. Remember, they are neoplastic, it's clonal, it is primarily and intrinsic to the eosinophil lineage specific, okay. So neoplastic eosinophilias are primary. Secondary, on the other hand, is a condition where you have other conditions implicated like parasitic or inflammatory disorders, lymphoid malignancies, unrelated to eosinophils. That is extrinsic to eosinophil lineage is secondary. Idiopathic, obviously, when the cause is unknown to us. So primary, as I've already said, it may be a myeloid or stem cell neoplasm, it may be myelodysplastic syndromes, systemic mastocytosis, all are clonal. Okay, all are clonal. On the other hand, secondary hypereosinophilias where you have infections, maybe parasitic, fungal, viral, atopy like eczema, allergy, asthma, medications, maybe antibiotics, NSAIDs, anti-epileptics, DRESS. Okay, DRESS, we'll be going into it in a bit. Now, coming to the GI diseases like eosinophilic esophagitis, gastroenteritis, inflammatory bowel diseases, lymphocytic variant eosinophilia, we'll be going into that. Immunodeficiencies, rheumatological conditions, and others like adrenal insufficiency and graft versus host diseases, solid organ transplantation, sickle cell anemia, etc. So they're all polyclonal, remember. Secondary hypereosinophilias are non-clonal or polyclonal, and they are the pathogenesis basically is the fact that there is release of cytokines like GM-CSF, interleukin 3 and 5. That causes the bone marrow precursors, that is the colony-forming unit, to proliferate and mature into eosinophils. That promotes the release of bone marrow eosinophils into circulation. Stimulates circulating eosinophils to enter into tissue and release injuring agents. These cytokines, okay, of which remember interleukin 5 is very important in the development of eosinophils, as I've already discussed. So these cytokines may be released by the diseased cells, or the diseased cells may cause the release of these cytokines by the non-diseased cells, surrounding cells. Now, eosinophilic non-neoplastic conditions like atopic dermatitis, which is an inflammatory disorder. Here you have these skin conditions. It's atopy. It is characterized by epithelial dysfunction and parakeratosis. IgE is usually elevated in atopic dermatitis, like all other allergic conditions. Now, chronic spontaneous urticaria is another condition. It's a heterogeneous mast cell-related disorder characterized by recurrent flares of and wheals as well as angioedema for more than 6 weeks, generally triggered in the absence of clear offending agents. Histological evidence suggests that eosinophils are abundant along with mast cells and expanded vasculature at the sites of skin lesion. Now, what is DRESS? Okay, that we were talking about. That's a drug reaction with eosinophilia and systemic symptoms. So you have maculopapular rashes that develop with multi-organ failure. Liver and kidney are most frequently involved, and the drugs that are typically involved in this case are the anti-epileptic drugs and antibiotics like ampicillin, linezolid, tapsone, nitrofurantoin, trimethoprim, vancomycin, rifampicin, isoniazid, etc. So according to the current pathogenic paradigm, drug-specific CD4 plus T cells activate and promote CD8 plus mediated immune responses towards different tissues. So 4 plus T cells activate and promote 8 plus mediated immune responses. Now coming to the gastrointestinal symptoms, or rather gastrointestinal manifestations of eosinophilic inflammation. There is a term called as the eosinophilic esophagitis. Now, that is a condition where the eosinophil count is elevated, that is more than or equal to 15 eosinophils per high power field. More than 15 eosinophils per high power field, right? Eosinophilic gastroenteritis, when eosinophilic infiltration to the gastrointestinal tract, which may be mucosal, muscular, or serosal, is more than 20 per high power field. Okay, so that is the term called as eosinophilic esophagitis and gastroenteritis. Eosinophilic colitis and proctocolitis, now that is a condition, an inflammatory condition, which typically affects children in the first few months of life, and the disease basically is considered to be an IgE mediated and cell mediated hypersensitivity reaction to food, especially to cow milk proteins that constitute the pathogenic determinant of this disease. Okay, the eosinophilic infiltration in the lamina propria is more than 5 eosinophils per high power field. Now, eosinophil related respiratory diseases. Okay, now that is very important because eosinophilic infiltration in the chronic rhinosinusitis, nasal asthma is all known to us, right? But how does that happen? Now, upper airways provide a first-line frontier against the airborne pathogens and irritants. Furthermore, the inflammatory events occurring at the level of the upper respiratory tract can prompt a significant increase in the IL-5 T helper 2 driven immune responses. Let's see. So anything like Staph aureus, aeroallergens, aspergillus, etc., all of which cause stimulation of the T helper 2 cells. The T helper 2 cells produce interleukin 4, 5, and 13, of which 5 is typically very important. The T helper 2 cells subsequently differentiate into B cells, and these B cells undergo class switching and produce local and systemic IgE. The IgE typically binds to the Fc receptors on eosinophils and mast cells and allows for edema, mucus secretion, and tissue damage. Recently, it's been proposed that reduced fractional exhaled nitric oxide, that is FeNO, is a surrogate marker for eosinophilic inflammation in the lungs in patients with concomitant asthma. Now, neutrophils in infectious diseases. All know that eosinophils have been implicated in parasitic infections like helminths, strongyloides stercolaris, can be killed and can act as antigen-presenting cells. Here, eosinophils were shown to be able to kill larval strongyloides and can act as antigen-presenting cells, stimulating T cell proliferation, T helper 2 cytokine production, and antibody production by B cells. Bacterial infections and bacteremia as well results in eosinophilia. Fungal infections, aspergillus especially, cryptococcus, and very importantly, clinically, eosinophilia may be a clue for the diagnosis of disseminated cryptococcosis. Now, this is a figure of aspergillus, just for some. You have this acute angle branching that is shown alongside for aspergillus. Now, coming to the viral infections, you have eosinophilia is a frequent finding in patients with HIV infection as well. That progressing to full-blown AIDS. Now, that is very important because human eosinophils CD4 as well as CXCR4 and are susceptible to infections by CXCR4 tropic. Something very interesting is lymphocyte variant for eosinophilia. Now, this is a condition resort to the expansion of cytokine producing aberrant clonal population of a T cell phenotype. Okay. So it's aberrant and it's clonal. It's the T cells. The T helper 2 cells produce interleukin 5, 3, 5 and 13, right? So it is important to note that 5 is very important because 5 is implicated in eosinophilia. In addition, these T cells are aberrant. Why? Because they are either CD3 negative, 4 positive, 8 negative, 3 positive, 4 positive, CD7 negative but 3 and 4 positive, or it is CD2 negative but 3 and 4 positive. So this disorder is usually indolent but infrequently progresses to T cell lymphoma and Sézary syndrome. Okay, so that is why it is very important to understand that this patient has a lymphocyte variant hypereosinophilia. The criteria for diagnosis is a long-term hypereosinophilia. Okay, bone marrow analysis showing abnormally high levels of eosinophil, elevated serum IgE levels and CCL17 and other immunoglobulins. Eosinophilic infiltrates are afflicting the tissues, so eosinophilic infiltration in the tissues, yes. Increased number of blood and or bone marrow T cells bearing abnormal immunophenotypes, that is shown alongside here. Okay, abnormal T cell receptor gene rearrangements as defined by the PCR methods, and evidence of excessive IL-5 secretion by lymphocytes. So it is very important because therapeutic strategies should be targeting these pathogenic T cells in addition to eosinophils. Okay, because they have a tendency to convert to T cell lymphomas and Sézary syndrome. Now coming to the pathogenesis of the eosinophilic disorders. Okay, the MBP1 is stored in the non-toxic form in it's a non-toxic
cytotoxicity against bacteria, parasites, and host tissue. MBP1 is found extracellularly in large amyloids consecutive to massive eosinophil infiltration and degranulation. The presence of MBP1 deposition in the esophagus, okay, remember eosinophilic esophagitis, more than or equal to 15 eosinophils per high power field. So there, the MBP1 deposition in the esophagus of a symptomatic patient with eosinophilic esophagitis suggests the use of extracellular MBP1 as a marker of the disease. Okay, MBP1 and eosinophilic cationic proteins have been demonstrated to regulate mast cell functions, including their activation and release of a diverse mediators like histamine, prostaglandin D2, GM-CSF, TNF-alpha, and interleukin 8. Furthermore, both proteins display antiparasitic and antibacterial properties. A high level of eosinophilic cationic proteins has been associated with several diseases, okay? Besides asthma and atopy and other inflammatory conditions, even the coronary artery diseases, even coronary artery diseases, yes. Eosinophilic cationic proteins have been implicated to increase the reactive oxygen species and have been implicated in the pathogenesis of coronary artery diseases. In addition, they have been also implicated in airway remodeling and formation of intractable nasal polyps by EDN, that is eosinophilic neurotoxin, induced secretion of MMP9. Now coming to eosinopenia. Eosinopenia as well as adrenal epinephrine administration. So eosinopenia has been reported in Cushing syndrome, acromegaly, and SLE. Drugs like corticotropin, corticosteroids, epinephrine, and histamine also cause eosinopenia. But remember, beta blockers can inhibit this adrenaline-induced eosinopenia and favor an increase in the number of circulating eosinophils. So patients receiving beta blockers might have eosinophilia. So eosinopenia of acute infection or inflammation is again very important. Why does that happen? That happens preliminary because of the sequestration of these eosinophils that has been ascribed to the chemotactic substances that are released during acute inflammation. Several of these chemotactic substances are released, of which C5a is preliminarily very important. Now, this is a golden era for eosinophil targeted therapies. T helper 2 cells can be inhibited by immunomodulators. They subsequently release interleukin 4 and 5, of which 5 is very important because it allows for eosinophil recruitment. So anti-IL-4, now we have the mepolizumab, which is an anti-IL-5 receptor antagonist, okay, which has been used in severe asthma. You can also use adhesion blockers, CCR3 antagonists, corticosteroids, lidocaine, P38 MAPK inhibitors, okay, which will all allow for reducing the airway hyperresponsiveness. So this seems to be a new era of eosinophil targeted therapies. So going back to your roots, right? We're all going back to our roots. We want to know about neutrophils. We don't want to know about eosinophils, because when we know our roots, we can build the foundation. Now coming to basophils. Now this is the least abundant leukocyte, okay, which accounts for about 0.5 of the total. A small inflammation can mobilize into the spleen, lung, and liver. Now, basophils and mast cells are two sides of the same coin. So what is the difference between the two? Yes, we'll go into that. Before that, basophils have this metachromatic staining, okay, which can be seen because of their cytoplasmic granules with Wright's, Giemsa, or toluidine blue. So this is the toluidine blue stain shown alongside. Okay, basophils can be phenotypically identified by immunohistochemistry and flow cytometry, by their Fc epsilon receptors, CD123 positive, though they are CD303 negative. Now, derived from the CD34 positive myeloid hematopoietic progenitors in the bone marrow, basophils are phenotypically and functionally distinct from other leukocytes, including mast cells. Mast cells reside in tissues, whereas basophils reside in circulation and can be recruited to the tissues. A key distinction from mast cells is the lack of CD117. Okay, so basophils lack CD117. They are CD117 negative. On the other hand, they show a high expression of CD123. In vitro derivation of mast cells occurs when CD34 cells are cultured, okay, with stem cell factor. This happens in vivo as well. When CD34 progenitors bind with the stem cell factor in the presence of IL-6 produced by the T cells, then in that case there is production of mast cells. On the other hand, when basophils, okay, are produced, then the CD34 cells are cultured with IL-3 in the absence of stem cell factor. So the presence of stem cell factor allows for the synthesis of mast cells in the presence of IL-6, whereas IL-3 in the absence of stem cell factor allows for the synthesis of basophils. Basophils contain histamine, yes, very important. They also contain other substances. We'll be just going into that. Now, stimuli for activating these basophils is allergens, HIV, helminths, ligands for TLR2 and 4, and IgD immune complexes. Basophil degranulation is largely restricted to signals induced by Fc epsilon receptor cross-linking or anaphylotoxins like C5a and IL-3. It is very important that IL-3 synergistically acts with IL-33. Okay, and that allows for basophil synthesis of cytokines. The only negative regulator of basophils is type 1 interferon. Okay, now IL-3 activation increases basophil expression of CD11b and 18, and that allows, rather potentiates its adherence to the endothelium. Okay, so it adheres to the endothelium and subsequently is released. Basophils can also release platelet activating factors in response to stimulation by IL-3. So IL-3 is typically important for basophils. So summarizing the production of basophils, we have IL-3, which synergistically acts with IL-33, activates the CD34 cells and produces the basophils. Basophils express Fc epsilon receptors, CD123 and 303 are negative. The only cytokine reported to negatively regulate basophil production is type 1 interferon. IL-3 activation increases basophil expression of 11b and 18 and thereby allows it to adhere endothelium. Peripheral blood basophils from normal human subjects respond chemotactically to the complement component C5a and basophil chemotactic factors released by the T cells. Basophils readily produce IL-4 and direct the development of IL-4 producing CD4 cells. Okay, so CD4 plus T cells thereafter stimulate the B cells to produce antibodies. So this is the complete thing about basophils. Right? Now coming to basophil activation test. Now this is a new thing, right? Now basophil activation test is a flow cytometry based test that can be performed on peripheral blood. Yes, basophils can be gated as 123 positive, Fc epsilon receptors positive and CD303 negative. The basophil activation state is determined by basophil expression of CD69 and CD63 and CD203C. So let's see what happens. In a resting basophil, you have CD63. Okay, this CD63 is a glycoprotein that is expressed in the membrane of the cytoplasmic granules of basophils. Okay, under the resting condition. CD203 on the other hand is a glycosylated transmembrane molecule. Basophils express low levels of CD203, which is increased when basophil is activated and may correspond to its piecemeal degranulation. So when an allergen comes, what happens? There is an increased expression of CD63 now from the cytoplasmic granules on the membrane. In addition, what happens is that the CD203 is also upregulated and there is piecemeal degranulation. So upregulation of CD63 and 203 are very important for basophil activation test. But what is the use of this test? The clinical use is in allergy, drug allergy, food allergy, respiratory allergens, chronic urticaria, etc. So now from the skin prick test that has been, or the patch test that we are using for allergy, okay, we can now go in for a flow cytometry based basophil activation test. The whole blood, that is the basophil activation test, is usually done in heparinized blood. Because other anticoagulants like EDTA or acid citrate dextrose can prevent basophil degranulation. Priming of basophils with IL-3, because IL-3 is the priming agent for basophil, it is required for basophil degranulation. So IL-3 can potentiate the degranulation, okay, and allow the expression of CD63, okay. However, it also causes a non-specific upregulation of 203. So keeping that in mind, we should go in for priming the basophils with IL-3. Now, role of basophils in other clinical conditions like autoimmunity. Okay, the proposed model is that the IgE anti-dsDNA or dsDNA immune complexes bind to basophil epsilon receptors. Okay, so IgE is binding to its corresponding receptors. That causes the basophil activation with homing to the lymphoid organs. So it homes in to the lymphoid organs, where the activated basophils produce IL-4. So homing of the basophils to the lymphoid organs allows it to produce IL-4. Okay, once this IL-4 is produced, that promotes the T helper 2 driven adaptive immune response and produces what is referred to as autoantibodies. So basophil has a role even in autoimmunity by allowing the production of autoantibodies by T helper 2 cells. Now, infections. More recently, basophils have been implicated in the initiation of T helper 2 immune responses within the lymph node and by enhancing the B cell class switching and subsequent production of antibodies. Basophils are the primary source of IL-4 in vivo, though IL-4 is also produced by CD4 plus T cells or the T helper 2 cells, but it is important to note that besides that, basophils are the primary source. Basophils immediately secrete IL-4, whereas CD4 plus T cells must undergo rounds of differentiation to express IL-4. Basophilia is the term when the absolute basophil count exceeds 200 per microliter. It may occur in a wide variety of conditions like infections and inflammations like tuberculosis, chickenpox, smallpox, influenza, autoimmune conditions as I've already discussed like ulcerative colitis and rheumatoid arthritis, CML, myelodysplastic syndromes, and other clonal disorders, okay, which are the neoplastic disorders, not in this seminar, as well as hypothyroidism. Now, mast cells. Mast cells are tissue-based inflammatory cells of hematopoietic origin that respond to signals of innate and adaptive immunity with immediate and delayed release of inflammatory mediators. Mast cells are central to the pathogenesis of diseases of immediate hypersensitivity and of mastocytosis, but are also implicated in host responses to pathogens, autoimmune diseases, fibrosis, and wound healing. Now, what is the difference between a basophil and a mast cell? Okay, let's see. Basophils express the IL-3 receptors. It is important, as I said, IL-3 is a very important factor implicated in the priming of the basophils. On the other hand, a stem cell factor and IL-6 are very important for mast cells. KIT receptors are expressed on the mast cells, so they are CD117 positive. Fc epsilon receptors, on the other hand, are expressed both on the mast cells as well as basophils. Basophilic mediators are chondroitin sulfate, basogranulin, IL-4, 31, etc. There are some common mediators with mast cells and basophils share. They are the histamine, granzyme B, leukotriene C4, PAF, IL-3, 13, etc.
Mast cell mediators like heparin, tryptase, and chymase are again very important because they are the ones which divide mast cells into two types. Now, mast cells are about 20 micrometer in size. They are ovoid and irregularly elongated cells with an ovoid nucleus and contain abundant metachromatic granules like basophils. The metachromatic granules stain with tryptase and chymase. Okay, so tryptase is the stain that is shown alongside here. Okay, and the mast cells can either be MCT type, okay, or they can be MCTC type. MCT type mast cells, okay, are present in the mucosa of the respiratory and gastrointestinal tract and increase in mucosal inflammation. MCTC type, on the other hand, are present within the connective tissues such as the dermis, submucosa of the gastrointestinal tract, heart, conjunctiva, and perivenous tissues. They produce both tryptase and chymase, whereas MCT type produces only tryptase. Development and trafficking of mast cells. Mast cells arise again from CD34 pluripotent progenitors like basophils, just that the receptors are different. Mast cell precursors circulate in the blood and home to the tissues where they mature. Okay, mast cell maturation of precursors in the tissues is dependent on a very important factor which I've already discussed, that is the stem cell factor. So mast cells are produced when CD34 cells, okay, are primed with IL-6, yes, and stem cell factor. So that is your mast cell. On the other hand, when I'm talking about basophils, please look at the slide below. Then that is CD34, okay, with IL-3, yes, very important, but absence of stem cell factor. So stem cell factor is expressed on the surface of the fibroblast, stromal cells, and endothelial cells through binding to the KIT receptors on the mast cells. Mast cell phenotype and behavior is altered by cytokines like IL-4, 5, and interferon gamma. IL-4 is the one which upregulates the expression of Fc epsilon receptors. IL-5 promotes proliferation in the presence of the stem cell factor. On the other hand, interferon gamma decreases mast cell numbers. Remember, interferon gamma is produced by the T helper 1 cells. Now, mast cells and wound healing. Mast cells are important immune cell type in skin and play an active role even in wound healing. So when there is an injury, neutrophils come to the site within 24 hours. That's the inflammatory state. Okay, but what happens is that there is vascular permeability which increases with the help of the protein present in mast cells called as the histamine. This histamine is released by the activated mast cells. Okay, there is also a degradation of the extracellular matrix produced because of the MMPs released by the mast cells as well as the neutrophils by their neutrophilic extracellular traps. In the proliferation phase, collagen synthesis and fibroblast proliferation occurs. The alpha SMA levels are upregulated. This alpha SMA, remember, is produced by the myofibroblasts. Okay, so when the macrophage, the F2 pathway of the macrophages,
into U10, and that supposedly results in the formation of TGF-beta, and that causes fibrosis. Okay, so fibroblast proliferation occurs here in the proliferation phase. Okay, and then you have the angiogenesis, which is again mast cell driven, mediators like tryptase, histamine, and VEGF, okay, which is implicated in the angiogenesis. In the final phase of the healing, the alpha SMA, which is released by the myofibroblast, results in contraction and increased collagen cross-linking. So now coming to mast cells and hypersensitivity. Type 1 hypersensitivity reactions have been implicated as a very important phenomenon in mast cells. Okay, so when you have antigens, they are presented by the antigen presenting cells.
Okay, and they stimulate the T helper 2 cells, which stimulates the B cells, which undergoes class switching, produces IgE. This IgE thereafter binds to the Fc epsilon receptors on the mast cells. Okay, repeated exposure to the allergen causes activation of the mast cells and release of mediators. The immediate hypersensitivity response occurs within minutes after exposure to the allergen. Okay. And the later response, that is the late phase reaction, occurs about 6 to 24 hours later. Now, there are several mast cell activation disorders. It may be primary, secondary, or idiopathic. Primary are the clonal ones. Okay, remember the clonal ones are not today's subject though. We have mastocytosis and we have the monoclonal mast cell activation syndrome. Mastocytosis can either be cutaneous or systemic. Secondary causes, which are non-clonal, that is IgE mediated, food, drugs, insects. It may be vancomycin or opioid mediated, mast cell hyperplasias in infectious neoplasia and in autoimmune conditions, idiopathic anaphylaxis. Idiopathic mast cell activation syndrome are the idiopathic causes. Now, mast cell activation through Fc epsilon receptor is central to the pathogenesis of all allergic conditions. And similar to that is the type 1 hypersensitivity pathogenesis that I've just shown. It results in immediate hypersensitivity reaction, which is determined by the preformed mediators that are released. It results in erythema, edema, itching in the skin, sneezing, rhinorrhea, okay, bronchospasm, edema in the respiratory tract. Okay, whereas in the gastrointestinal tract, you have symptoms like nausea, vomiting, diarrhea, and cramping. In the late phase reactions, mediators like cytokines and chemokines do play a very important role. Late phase reactions are characterized by edema and leukocytic influx and may play a role in persistent asthma. Pathological excess of mast cells have also been seen in clonal disorders like mastocytosis, where there are activating mutations in KIT. Mediators of mast cells like histamine, prostaglandin D2, and platelet activating factors have been implicated in symptoms like headache, hypotension, urticaria, with or without angioedema. Okay. You also have prostaglandin D2, which results in mucus secretion, bronchoconstriction, and vascular instability. Platelet activating factors have been implicated in abdominal cramping, pulmonary edema, urticaria, bronchoconstriction, hypotension, and arrhythmias. Pro-inflammatory cytokines like leukotriene C4 and D4 are implicated in mucus secretion, edema formation, and vascular instability. Chemokines and tryptase have been implicated in acute inflammation, endothelial activation, and consecutive inflammatory reactions. Now, a very gray area of interest for young pathologists here is the non-clonal mast cell activation syndrome. This is a new entity. Pathologic hallmark of non-clonal mast cell activation syndrome is the inappropriate activation
threshold for the activation of mast cells. Aberrant expression of receptors and mediators shifted towards an allergic immune response, or changes in the tissue environment that affect the expression and function of the mediators. There may also exist defects or changes in the downstream signaling pathways for mast cell activation. So finally, okay, we have some key takeaways from today's seminar. We have the first key takeaway. Neutrophils are the most abundant cell type in the human body, and phenotypic heterogeneity and functional versatility makes it unique. Neutrophil extracellular traps are implicated in a wide array of conditions like inflammation, thromboembolism, ARDS, autoimmunity, and carcinogenesis. Eosinophil extracellular traps are unlike the neutrophil extracellular traps, as they are mitochondrial rather than nuclear. Eosinophil extracellular traps are implicated in atopy, asthma, and inflammation. With the discovery of mepolizumab, a newer generation of drug targeting eosinophils is underway. Basophils and mast cells are two sides of the same coin.
And very interestingly, basophil activation test is paving a new way to ascertain allergies and atopy by flow cytometry. Thank you so much for your patient hearing. I hope I had something to say, something new. Now, that's it. Thank you so much.
Thank you so much.
Thank you so much, sir.
At the very outset, let me say an excellent presentation. Wonderfully done, and I hope the big bosses of the state are seeing we have a new star coming up. Wonderfully
Thank you,
done.
sir.
Excellent go. Very well presented, very well compiled, very hard work. We can see that, with what all has been taught and what all has been put in, with the references and the amount of hard work you have taken in to put it up. You can stop presenting so that we can see you. You can put your video on so that we can see you and everybody can
Yes,
see
sir.
you. And then you can,
Thank you, Shristi. Excellent presentation.
that's your
Thank you
boss,
so much,
Dr.
ma'am.
Mamata Didi.
Thank you, thank you, thank you.
Thank you so much, madam.
Dr. Manoj Gupta is saying very nice presentation.
Thank
Excellent
you, sir.
presentation, Dr. Srishti. Very, very well done. You have a
Thank you,
very
sir.
bright future, and we can see you, and we will be having you here as well as in other forums to speak on various topics. Very well
Thank
done.
you so much, sir. Thank you, sir.
And we will send you the recorded version of this entire thing for you to
Yes,
have a
sir.
look,
Yes.
and we'll share it with everybody on the Google Drive and as well as everywhere, so that people can learn from this. As you
Thank
know,
you
that
so
this
much, sir.
platform which we have is primarily trying to compile topics into a audio visual digital encyclopedia, which is being viewed by people across the globe. By
Yes, sir.
tomorrow
Yes,
morning,
sir.
there will
Yes,
be more
sir.
than 1,000 people who will be have must have watched your video and would have learned from it. And we keep receiving remarks, comments, as well as appreciative notes from all over the world across. Wonderful lecture, Srishti. It was a
Thank
pleasure
you.
having
Thank
you
you.
here on this platform.
So it's an
Very,
honor and
very well
privilege to
done.
be a part of it, sir.
No, the honor and privilege is all ours for a person
No,
like
sir.
you
It's
giving
all mine.
such a wonderful presentation.
Wonderful,
You're
Thank you,
yes.
sir. Thank you, sir.
very, very, very well done. All credit to your teachers who have taught you
Yes,
so
sir. Yes,
wonderfully.
sir. All credit. All
Brilliantly done.
credit, sir.
Thank
Yes,
you. And
sir.
one of your teacher is
Thank
there,
you.
right
Thank
there.
Yes.
She's smiling,
Thank
I
you,
can
ma'am.
see.
I am
Thank you,
proud
ma'am.
of I am proud of her. She
Thank you
has
so
given
much,
a
madam.
message
Thank
in
you
So,
so
depth.
much.
right. So,
Yes,
hope to,
yes.
and she'll be
Thank you
here
so much.
back again next week for the next presentation, session
Yes,
2.
sir. Yes, sir.
Yes.
So, we
Yes,
are
sir.
all looking
We
eagerly
will
for
wait for
that.
that. Hmm.
Right. Okay, then
Yes,
take
sir.
care, everybody. Good night.
Thank
God
you.
bless you,
Good night.
Srishti. Well done.
Thank you.
Thank you, sir. Thank you, ma'am.
Bye bye. Take care. Bye.
Bye. Thank you. Good night.
Bye. Good night.
Good night.
Good night.